Hello everyone, I am Karen Alvarez. Today I am going to talk about a new topic, procedural volume and outcomes for transcatheter aortic-valve replacement. I share my social networks in Facebook, Twitter, YouTube, and Instagram. Definition: Transcatheter aortic valve replacement is a minimally invasive hair procedure to replace a nerve aortic valve that fails to open properly. Transcatheter aortic valve replacement is sometimes called transcatheter aortic valve implantation. May relieve the signs and symptoms of aortic valve stenosis and improve your overall health and quality of life. TAVR can also reduce the risk of the death.
The Heart Institute, CHI Health. In 2002, Dr. Crebier implanted a transcatheter aortic valve replacement, or TAVR, in a critically ill 57-year-old man. It was a success, and the procedure was hailed internationally as a breakthrough for patients who faced death due to a common problem called aortic valve stenosis. Approximately 12.4% of the population has aortic valve stenosis. This is basically a narrowing of the aortic valve, the main outflow valve of the heart, and blood is restricted to flow out to the rest of the body. It's typically caused by calcium and scarring as we age. People with aortic valve stenosis have a hard time walking short distances or climbing stairs. Symptoms include breathlessness, angina or chest discomfort, and fainting spells. Once these symptoms occur, they need treatment soon. Survival rates are only 50% at 2 years without replacement. Open heart surgery to repair or replace the valve was the only option, but it really wasn't an option for a lot of people. Some people aren't healthy enough for open heart surgery. That's who the revolutionary approach called TAVR was originally developed. This is how it works. Patients are usually awake. They come outpatient to the cath lab. A small incision is made in the groin. A wire is then inserted through that artery, and a sheath is placed to facilitate the valve deployment. Once the sheath is placed, a wire is carefully threaded through the restricted aortic valve. Initially, TAVR was offered only to patients who were inoperable or prohibitive risk for surgical aortic valve replacement. Following that, we had trials showing benefit in high risk and intermediate risk. And now, more recently, in March at the American College of Cardiology annual meeting, they presented the data for the low-risk patients where TAVR was not only non-inferior, but in certain regards, it was actually superior to surgical aortic valve replacement. We are still awaiting approval for this low-risk group, which actually represents 80% of the aortic valve stenosis patients.
Application in the nursing. Nursing action during TAVR. Preoperative admission and general assessment of the patient's condition. Intraoperative follow the phrase of the safe surgical appropriate. Collaborate with the doctor in the patient general anesthesia. Apply the function of cross nursing on circulatory nurse and performing transcatheter echocardiography. Post-operative control of the vital signs of the patient, hydrate balance control, keep the patient in absolute rest, medication administration according to the medical prescription, and icement paying the possibility complications.
Valve replacement, or TAVR, is a less invasive catheter-based procedure. It is revolutionizing cardiac care and reducing the need for traditional open-heart surgeries. It's a treatment for aortic valve stenosis. That's when the aortic valve in the heart functions poorly, usually due to calcification, reducing blood flow throughout the body.
We don't take out the valve in the patient. We just move the valve or the stuck leaflets out of the way without having to make a surgical incision at all.
A typical TAVR involves inserting a guide wire into the femoral artery and threading it through the aorta, then around the aortic arch and into the stenotic aortic valve and left ventricle. A common TAVR procedure involves delivering a new valve with a balloon catheter over that guide wire and into the stenotic valve. The balloon is then inflated, opening up the old valve and putting the new valve in place. The wire and catheter are then removed, leaving behind a new functioning aortic valve. Here you can see the new valve opening and closing and able to restore normal blood flow.
The recovery for those patients, especially those patients that are older, is much faster. Most of our patients stay overnight, and almost everyone goes home within 48 hours.
Cardiologists at UC Davis Health were the first in the Sacramento area to offer TAVR. They continue to lead the way in providing groundbreaking treatment options to patients with heart and vascular disease.
To have the opportunity to provide a minimally invasive procedure for those particular patients who need it is really life-changing for many of them.
Visit health.ucdavis.edu and search for TAVR, TAVR, to learn more about TAVR at UC Davis.
Cons: belling, blood vessel complication, problem with the replacement valve, such as the valve spelling outgoes, the place leaking, heart rhythms problem, arrhythmias, and need for pacemaker implantation, guidance, heart attack. And pros: minimally invasive procedure, risk of the infection and the belly are lower compared to the traditional open heart surgery. TAVR, a replacement valve generally functions better than valves used open heart surgery. TAVR valves legs generally last longer than other types of the replacement balance.
Common valvular heart disease that we see in the elderly population. The aortic valve sits in between the main pumping chamber of the heart and the aorta, the main artery that delivers blood throughout the body. As that valve becomes narrowed and can't open as far, less blood can come out of the heart, less blood to feed the organs, and symptoms tend to develop. Shortness of breath, fatigue, exertional chest discomfort, congestive heart failure are all manifestations of severe aortic stenosis as that valve narrows down.
It's impressive how many people are willing to accept those symptoms. And our aim is to, one, tell them that we can help to prevent deterioration of the heart muscle function, and to give them, one, better survival, a better quality of life.
At Reading Hospital, one of the most important things we developed very early on is a very effective heart valve team. A heart valve team consists of interventional cardiologists like myself, cardiac surgeons, as well as our heart valve coordinator and the support team.
It allows for a team approach to the patient. They're seeing the cardiologist and the cardiac surgeon at the same time, and we discuss the patient, their issues, their concerns, our concerns, and we're able to give them the best treatment. We can do surgical valve replacement, or we can do what we call TAVR, or transaortic valve replacement.
And that's a way to replace the heart valve without having to do surgery. We can place that heart valve through an incision in the leg artery. We can then thread a little wire through that opening, put a valve over that wire, deliver that valve inside the old narrowed valve, and put a whole new one in its place. So we no longer use general anesthesia. It's done with conscious sedation. The whole procedure nowadays takes about 40 minutes or so, and most people go home within 1 or 2 days. So TAVR was a fascinating approach to managing aortic stenosis because it initially opened up a treatment avenue for a whole group of patients that had no options, helping this usually older, sicker group of people who couldn't get through an operation get their valve fixed.
However, studies have shown that really the TAVR valve has become as good as the surgical valve replacement. And so we now are able to do that in people who we call at moderate risk.
For those of us that take care of these patients, it opened up a whole new group that we can offer this procedure to, knowing with good clinical trial data behind us and good outcomes that they're going to get a great result from a transcatheter approach. The valves, as soon as we implant it, start working instantly. Patients that day are up and walking around, and most of them have a pretty significant improvement in their symptoms and functional activity level as soon as the day of the procedure.
We're able to get them back to doing everything that they want to very rapidly, and also to have relief of whatever symptoms they may have presented with to us to improve their quality of life.
The Reading Hospital Heart Valve team has been working together as a group since around 2011. We've been implanting valves since 2012 and have had an excellent track record. Our outcomes are consistently better than national standards in regards to complication rates. Our hospital lengths of stay are significantly shorter, and the overall experience of the patient is just amazing.
Use it applied in Ecuador. The transcatheter aortic-valve proteins implying that has been consoled in recent years has safe and effective treatment alternative for patients with severe and symptomatic aortic stenosis who are at a high surgical risk. The transcatheter aortic-valve replacement has already been performed in Ecuador. There are currently 2 devices in use: the Edwards Sapiens valve from Edwards Life Science and the Core valve from Medtronic, aged, which is when characteristic different and anatomical aortic requirements.
Hi, I'm Dr. Abhishek Sharma, structural heart disease specialist at Gunderson Health System. In this study, we evaluated the relationship of body mass index with outcomes after transcatheter aortic valve replacement. We used transcatheter valve therapy registry of National Cardiovascular Disease Database to evaluate this question. Registry data was linked to CMS database to assess the association of body mass index with 30-day and 1-year mortality using multivariable Cox proportional hazard models. We included 32,000 patients who underwent TAVR, and we found that these patients in different BMI categories were different at most baseline and procedural characteristics. To take into account for this baseline difference, we perform multivariable analysis. And our result shows that compared to normal weight patients, underweight patients had higher mortality at 30 days and 1 year after transcatheter aortic valve replacement. Conversely, compared to normal weight patient, overweight patient and those with mild obesity have better survival 1 year after transcatheter aortic valve replacement, basically suggesting an obesity paradox for post-transcatheter aortic valve replacement survival. The finding of obesity paradox in our large study of 32,000 patients is not totally surprising, because an obesity paradox have been noted in other cardiovascular disease as well. including coronary artery disease and heart failure. These existence of this paradox have been partly attributed to poor metabolic reserve in underweight patient compared to overweight patient. However, I would like to emphasize that body mass index is not an ideal anthropometric parameter to assess degree of adiposity, and whether the association of body mass index and outcome post-TAVR is causal or merely an association cannot be determined from our study. Thank you.
We hope.
Conclusion. In conclusion, transcatheter aortic valve implantation program include both the transfemoral and anterograde transapical approaches and associated with comparable mortality as predictive by surgical risk calculation for the treatment of patients at very high surgical risk. TAVR can relieve the signs and symptoms, and it can be a effective option to improve quality of life in patients who oversight have limited choices for repairing of their aortic valve and may improve survival in people who have same symptoms.
Stenosis is that the aortic valve, or the door that connects the left ventricle or the main pumping chamber of the heart to the main blood vessel of the heart, called the aorta, does not open all of the way. And as a result, the heart begins to suffer.
So there really is only one treatment for aortic stenosis, and that's aortic valve replacement therapy. We're fortunate now to have several different ways to replace the valve, but in the end, the valve just needs to be replaced. So aortic valve replacement therapy comes in two forms. One is traditional open heart surgery, where the actual old heart valve is taken out and cut out, and a new heart valve is sewn in its place. That can be done through big incisions, that can be done through small incisions, and it works very well. The only downside of traditional open heart surgery is that it's invasive. And for many patients, some of whom just don't want to go through open heart surgery, others who are not well enough to go through open heart surgery. There we have the second option now, and it's become a relatively mature option over the last decade or so, and that's transcatheter aortic valve replacement. We call it TAVR. TAVR is basically a way of getting a new valve inside of you without making a real incision. What it means essentially is the valve itself is loaded within a stent, and that stent is then inserted into your body. Most commonly, that's inserted through one of the arteries in the leg. That valve then works its way up the artery, it's loaded on a wire, and basically is positioned where your current diseased aortic valve is, and the valve is just blown up. When the valve is blown up or inflated, it pushes your old valve out of the way, and now you have a new functioning valve in place of where the other one used to be.
Patients who have severe aortic stenosis can qualify for TAVR in many different ways. There are commercial indications for transcatheter valve replacement if patients have significant aortic stenosis and they have at least an intermediate or a high operative mortality risk. That means that their chances of dying with traditional open heart surgery are greater than 3%, provided that they have the appropriate anatomy, or that the heart is of the appropriate dimensions and positions that would allow for a valve to sit well.
Probably the thing I'm most proud of here at Washington University School of Medicine and Barnes Jewish Hospital when it comes to our transcatheter valve program is the way we evaluate patients. Patients who are sent to us for consideration of aortic valve replacement therapy get to be seen not only by a surgeon, but also with a cardiologist. So a patient will come to our institution, they'll have their testing done, we'll review their testing together, we'll walk into the room together, we'll We'll ask questions of the patients together, and then we'll make a treatment decision for them together. Some patients are fantastic candidates for transcatheter valve replacement, and that's absolutely the direction they should go in. Others are not good candidates for transcatheter valve replacement, and they may need open heart surgery.
Our transcatheter aortic valve replacement program at Washington University School of Medicine and Barnes-Jewish Hospital Heart and Vascular Center is pretty unique. We have the largest volume in the area, which allows us to have access to both commercially approved devices and also participate in clinical trials evaluating new technology that improves on the currently commercially available devices. As a result, when patients get evaluated for a TAVR procedure at our institution, we're able to select the right prosthesis for the right patient, depending on the patient's anatomy and other characteristics that would allow us to have a very successful result.
Thank you for your attention. See you soon.